Okay, thank you everybody for coming. And this will be real quick. It's a very practical lecture, so we'll get into more theoretical things as the year goes on, but I thought in July we'd start very practical. So here's our objectives, so you can read them real quick. Okay, yeah, I'll use the mouse. Okay, so today we're going to focus mostly on acute heart failure and develop a practical approach to dealing with these patients as they arrive. They're often very challenging. Sometimes they're extremely sick, and sometimes they come in and they don't look so sick, but the next day they become extremely sick. So having an approach to them that you can use all the time and having a framework for dealing with them makes taking care of them much, much easier. The first place to begin is to have in your mind your approach to differential diagnosis of not just heart failure, but all cardiac issues. The heart actually is a fairly simple organ. It's not like the kidneys or the liver or anything. It's kind of complicated. That's why we go into cardiology, because it's easy. The heart is simple. But the heart exists as sort of four layers that sort of overlie each other. The layer that we see most commonly is the myocardium. That's what we see. That's the visible thing. When you say heart to people, what they're looking at is the myocardium. And so there are certain conditions that are associated with the myocardium, of course, cardiomyopathies of various sorts, but also things like hypertension. When you think about hypertension, hypertension impacts the heart through the myocardium, causes hypertrophy, causes stiffness, causes all kinds of problems. So the first thing you want to look at when you think about heart conditions and why a patient's in front of you is it a heart global anatomical or physiological problem? So that's the first thing. The second thing that's very important, especially in an environment like Tampa, is coronary disease. Are the coronaries a problem? Sometimes it's straight atherosclerotic coronary disease, sometimes an anomalous congenital coronaries that start from one side of the body, cross over to the other side, taking a path that is dangerous. So that could show up as an acute heart failure patient. So the next layer that you think about is the coronaries. The next layer is the four valves. Any valvular disease can present as heart failure. So it's easy because we can get an echocardiogram and see which valve is the problem. But you always want to think if it's a valvular issue, if you don't have the echocardiogram, you have your physical examination, which can also tell you quite a bit about valvular lesions. So that's the third layer. And then the fourth layer is the electrical layer. And that usually shows up as tachycardias, bradycardias, PEA, asystole. So you want to think about whether or not an arrhythmia is the cause of your problem. The interesting thing about arrhythmias is that they can cause the problem and then go away. And so now you have the patient in heart failure. You don't know what caused it. They're in perfectly sinus rhythm. And so the arrhythmias tend to be challenging because they are instantaneous and can then disappear. But that's the four things that I always think about, and I think about them in layers. And so when you develop an approach to cardiovascular disease that's in layers, you're more likely to find out what the problem is. We often talk about ejection fraction, but in acute heart failure, it turns out that the ejection fraction is actually not a big player, because a patient's ejection fraction can be anything and they still show up in acute heart failure, right? So it can be a perfectly normal ejection fraction, like the top echo, ejection fraction 50, 55, 60%, 65%, or it can be the bottom echo where the ejection fraction is somewhere between 15 to 20% and the heart's barely moving. Anything in between those can show up as acute heart failure. So ejection fraction ends up being not as helpful for acute heart failure. Of course, we need to know what it is so we can treat the patient and find out what's causing their problem. But the important thing is that any ejection fraction can show up as an acute heart failure. What really determines the diagnosis of acute heart failure is actually at the pathophysiological level. And this is important for you to think about because, again, cardiology is one of those things where our pathophysiology is front and center when we're dealing with the patients. So by definition, acute heart failure is cardiac output that is insufficient for the body's needs. So that's the pure definition of heart failure. And so we like to start at the cardiac output and then work our way backwards. Cardiac output is a product of the stroke volume and the heart rate. So we already talked about the arrhythmia issues that can cause you to have a low cardiac output. But most of the time when the patient shows up in acute heart failure, they're tachycardic. And the reason they're tachycardic is because the body, the autonomic nervous system, is trying to use heart rate to maintain cardiac output. The problem is elsewhere. So when you see that patient with a heart rate of 110, 115, that's not the problem. That's a potential solution to the problem. That's the body's way of trying to hold the fort until you figure out what the actual problem is. And the reason I say that is don't treat it, because that's actually probably keeping the patient alive. So sometimes when we see a heart rate of 115, 120, somebody wants to jump on it with a beta blocker or something, you will kill the patient because they're trying to maintain cardiac output using that heart rate. The problem is usually on top. And so leave the heart rate alone when you see the patient and just assume that it's trying to help and it's not hurting, and find out what the problem is that's keeping the stroke volume insufficient despite the increased heart rate to keep the cardiac output low. So that's the way your thought process ought to be, is that the problem is on top, not the bottom. So on the top, we have three important levers that are all contributing to different degrees to that stroke volume that's causing the cardiac output to be low. One is afterload, the actual work that the heart is pumping against. It has to work against in order to get the stroke volume through. The other is preload, the baggage that that heart is carrying that it has to deal with in order to get the stroke volume through. And the other is contractility, which is the strength of the muscle that will help it defeat the afterload and defeat the preload. So if the contractility is insufficient to defeat the preload, you're going to get heart failure. If the contractility is insufficient to defeat the afterload, you're going to get heart failure. If the contractility is fine and your afterload is too high, you'll get heart failure. If the contractility is fine and your preload is extremely high, you'll get heart failure. So those are the three things that you want to think about as you think through your patient with heart failure, because it's one or a combination of those three is the reason why the stroke volume is insufficient, and it's the reason why cardiac output is insufficient. So that's a simple clinical approach to pathophysiology you can take with you to the bedside, because you're trying to now figure out what's the afterload, what's the preload, what's going on with the contractility. Because solving that will help you take care of the patient. So clinically, we put the patient into the Forrester matrix. And it usually starts out looking really easy because using the preload and afterload and all of the information we have, we can tell what the acute heart failure clinical picture looks like. The first one is a profile one with a warm patient that is dry. They don't have congestion. They're just sitting there in front of you. They have heart failure, but now they look actually pretty good to you. So that's a profile one patient. The profile two patient we'll get back to, but the profile three patient is a patient that we typically see. 90% of the patients that you're going to see in acute heart failure are going to be profile three. They're going to look pretty good in terms of their circulation and their perfusion, but they're going to be extremely congested. And so we'll deal with those. Those are the easiest patients. That's probably what you're going to see. And then clinically, you can see the neck veins in that patient. We have their classic case of the patient who's perfusing fine, but they are extremely wet. The profile two is a patient who is the classic cardiogenic shock, right? They're cold because their perfusion is low, and they're dry because they're not congested right now. So those patients, again, are pretty easy to recognize, and we'll see how you work through that with some examples. Profile four is actually an extremely sick patient. They're both cold and they're wet. So they're in real trouble. And they're the patients that are probably most likely to die because they have multiple issues that have now conspired to really weaken the heart, and the heart is not functioning very well at all. So the patient is using everything they have to compensate, and it's still insufficient. So they're in real trouble. So we always do this grid, a four grid, and people leave, especially interns, they're like, okay, this is easy, I can figure that out. What in clinical practice, as the second and third years will tell you, is that that's not how it is. It's actually more like this. Patients can show up anywhere in the matrix, right? So I have 6 patients that are on our service right now. And so what you want to think about is to get out of your mind that 4 in a box and start to think a little bit more expansively. And we'll work through, I have 3 cases that we'll work through. And by the end of it, you'll have a very good idea how to do it. But that's basically what we do in heart failure. That's how we approach patients, is what I'm going to show you shortly. And how we manage patients and how we decide what to do. on a patient and decide what's not working for the patient and do something different. So here we have 6 patients. They are within the matrix, and you have patients with all degrees of congestion and perfusion, and that's how they show up in the hospital. They don't show up classic in one of the 4 boxes. They show up like this. And so you have to use your clinical acumen, test results to figure out what's happening and what you're going to do about it. The goal always is to bring the patient, no matter where they start in this, back to box A, right? That's the dry and well-perfused patient. That's your job. Patient shows up in heart failure, in any of the other boxes, your job is to bring them back to box A. And so when you visualize it, that tells you how much work you have to do. And it also tells you what you need to do, because now you have a goal, is to bring them back to box A where they're dry and where they're well perfused. And then you choose your therapeutic agents to help you do that. So that's the goal of all heart failure, is to put the patient in box A. Why do we want to put them in box A? Box A is where you begin to apply your guideline-directed medical therapies. It's where you start to keep the patient in box A because, again, they're dry and they're well perfused. You want to keep them that way, regardless of what their heart function is. And so you begin to put your evidence-based guideline-directed medical therapy on those patients when they're in box A. If you put the patient on guideline-directed medical therapy when they're in another box than other A, you might undermine your treatment. So generally, we like them to be in box A. And that's when we begin, you'll see people, we talked about the heart rate. If you start a beta blocker in a patient who's still using their heart rate to maintain cardiac output, you're not going to help them. So always think about when they're in box A, then you want to start your guideline therapy treatment. Don't do it early because you might undermine their therapy. And the reason we start patients in box A on guideline-directed therapy nowadays is that if you look at the key benefits of each of them, we like the mortality, but that's going to take some time, right? Each of them reduce mortality. That's why they're so good, but it's going to take us time. What we're really, really interested in when we put them on box A is the hospitalizations, right? They're in the hospital now. We want to keep them out of the hospital. So the reason we start them in box A is for current and future hospitalizations. You can see that all 4 of them decrease hospitalization by a lot. So we want to put the patients on these medicines because we're interested in their hospitalization, not their mortality and their other things. That's going to take some time for that to occur. So that's the important thing. If someone asks you why we're putting them on guidelines, the hospitalization is what we're actually looking for. And Dr. Abdullah and his team, they did a good job showing us why we want to put these patients on their GDMT while they're still in the hospital, because we want to prevent subsequent hospitalizations. And so you can see here 50% reduction in future hospitalizations for that patient, whether you're looking at 30 days or 6 months. That's very important. That's what makes this data so relevant. And that's what makes that the key to our approach, is to put the patient in the box A and then get them on guideline therapy. That is excellent heart failure management. If you do that, no heart failure attending can do any better. That's the actual job, right? That's you might be able to do better than they are because they're running around all over the place. But that's the key, and this is why. Okay, so let's do a few cases and then we'll finish up. This is going to be a brief lecture. I told you that it's not going to be too long. So the first case, again, on the service, 72-year-old male, followed by our service as an outpatient for ischemic cardiomyopathy, known ejection fraction of 15 to 20%. Has chronic systolic heart failure, which is well managed, and he presents to the ED with complaints of progressive dyspnea, non-productive cough for the past 2 weeks. His legs are extremely edematous, and he denies any fevers, denies any chills, and actually he was in the hospital 2 months ago, and now he's back in the hospital. His blood pressure was 110/65. His heart rate was 90. His NT-proBNP was 15,300. His lactate was fine. His chest X-ray revealed some older bilateral pleural effusions, which he kind of always there, but there was no clear pulmonary edema. And then you can see his comorbid conditions listed there: his coronary disease, previous stents and things, HIV status from transfusions, and hyperlipidemia, hypertension, COPD, and chronic anemia. And that you're looking at is literally his picture that they took. That is him, okay? And you can see his legs. The edema is basically anasarca at this point because it's crossed his knees and it's in his thighs. And so he's really in bad shape. So the question then is, so you come down to the ED, you see this person, and the first thing you're going to do is, where is he on this matrix? But before you even start thinking about what you're going to do for him, you have to put him into the matrix, right? So that's why we call it the matrix game. That's the first thing you want to do, is to say, where is he? So what do you think? First of all, he's B. How many say B? How many say C? So let's figure it out. First thing you do is he wet or dry? He's wet, right? So you're over on the right side. So you can ignore A, D, and F. So you're halfway there. And then the second question is he well perfused or is he poorly perfused? So is he warm or cold? He's warm. So now you're in this upper box. You can ignore C. So is he B or E? So the way you tell that is, what was his blood pressure? It was fine. So his blood pressure is normal. So he's actually in line with the A, which is normal blood pressure. So it's not E. So you're right, it's B, but you have to figure it out, right? So by the end of this lecture, the point is you don't guess. You already know. You look at the patient, you know where he is or where she is on the box. And then you can begin your treatment. So we've identified it's B. The treatment is the arrow. What's the arrow? Diuresis. Exactly. So the arrow is diuresis. And that's all he needs because his blood pressure, everything's already okay. So decongestion. The goal is net diuresis. So we want to decongest the patient completely. You'll have other lectures on diuretics and how to choose diuretics. But the important thing is that is a key to managing patients who are in that upper left-hand box, is that you have to be aggressive in your diuretics, get the fluid off of them, and get as much off of them as you can. So that's the therapeutic goal for that patient. Sometimes you can do it using the intermittent BID that we use. Oftentimes we actually prefer TID in some of those patients because we really want to get them out. Other times we will put them on continuous IV therapy for the first 24 hours to just get as much fluid off of them as we can. Some patients, like that guy, he had severe scrotal edema. You can't treat scrotal edema with just loop diuretics. You need to add either metolazone or acetazolamide or another thiazide because you have to get the deep tissue edema out. And the loop diuretic by itself is great at taking the peripheral. You can diurese the patient, they put out a ton of fluid, but you're not getting the deep tissue. So to get that deep tissue out requires you sometimes to use the sequential nephron blockade. And so when you put the patient on metolazone, you'll see that the scrotal edema immediately begins to resolve. It's not really clear why you require the sequential to get the deep tissue, but you do. So you'll diurese the patient, the whole rest of their body looks good, but then those deep tissues are still edematous. So diuretics, and on here, I put this on here for you so that you can see the comparison of the different diuretics, and most of you know that already. We often use furosemide and bumetanide. They're interchangeable intravenously. They're not interchangeable orally because their oral bioavailability is different. So those are just the important things to keep in mind. Ethacrynic acid is important. We don't use it. The reason I bring it up is that it's expensive, but it's the only loop diuretic that does not have sulfide module inside it. So if a patient is truly sulfur allergic, the only thing that they can take for loop diuresis is the ethacrynic acid, or Edacrin. And because of that, it's very, very expensive. So you want to make sure the patient really does have a sulfur allergy.
But furosemide has a little sulfur group, doesn't it? So
it does.
If they can tolerate that, then
if they can tolerate that, then they don't
waste
have
your money.
Yeah. We usually test them with furosemide and see how they are. And most of the time they do just fine. So when you are diuresing the patients, if you remember, we said net diuresis. This is an actual patient actually on our floor right now. He has put out 23 liters. And by now, it's actually probably like 30 liters of fluid. But he has what we call the Christmas tree sign. Okay. If you take his eyes and nose, and it's a Christmas tree. So what EPIC does is it compiles the total amount of intake, the entire admission, with the total amount of output, the entire admission. Even though we've taken out 23 liters here, he has put in 20 liters. So he has drank 20 liters of fluid in the hospital. And you're like, well, where's he getting it from? Right? Where do you get that much fluid from? So, and we do the urine sodium. Urine sodium is great because he's diuresing just fine, right? But the input is outrageous, and we're going nowhere, right? So even though we've done this incredible job diuresing him, he's putting it all back in, and he looks exactly the same as he looks when he came in, and he's 20 days into his hospitalization, and we're going nowhere. So the point is that it's net diuresis. Pay attention to how much is going in. It doesn't have to be like 800 cc's. The patient is not going to stand for it, but a reasonable amount where you can balance how much you're getting in. And so for him, what we had to do is to resort to a combination therapy where we have both metolazone, acetazolamide, and his loop diuretic. So he's getting 20 milligrams an hour of Lasix plus those other agents, just so we can stay ahead of his input. And he refuses to stop his input. So we diurese him as well as we can. We discharge him. He's probably going to be back in 2 weeks. But again, the important thing is that you're doing your job in the output. He's doing his job in the input.
Dr. Agocha, some of the residents told me that the patients, they Uber in stuff.
Yes.
Yeah.
Like candies and maybe
Yeah.
he's Uber and
He's got chips. And so you're like, where are you getting all this stuff? Sodas and things like that. So where is he getting it? He probably is. He doesn't get a lot of visitors, so he probably is bringing it somewhere. But the fascinating thing about this is that he's on the heart failure floor. So the nursing assistants document every ounce that he takes in. So the data is actually excellent. You're like, how did he even document all of this? So the data is excellent. His input, his output is all very well documented. But the key thing is if you're not going anywhere, getting anywhere with your patient, flip through and see why that is. Okay, so next case. 69-year-old female transferred from an outside hospital after presenting there with altered mental status, progressive dyspnea, hypoxic respiratory failure. She was immediately intubated in the ED, started on amiodarone because her rhythm was a AFib RVR at 140, and her chest x-ray just was whited out, florid pulmonary edema. Lactic acid was 8.53 on presentation. Blood pressure was 97/53. Heart rate was 100. They did a stat echo, and it showed ejection fraction less than 20%. The RV was blown, very big, dilated, and severe dysfunction. And her comorbid conditions, what we found out, she already was known to have cardiomyopathy with an ejection fraction of about 20 to 25%. She had known AFib and the tachybrady syndrome, and she's already had prior CVAs, diabetes, known systemic hypertension, and pulmonary hypertension as well. So she presented, you call down to the ED, you're seeing her, where is she on the matrix? Right, so she's clearly wet, so we're not dealing with the parts on the right. She's very cold because she's hypertensive and now her blood pressure is 97. Sometimes when they tell you a blood pressure is 97, and you're like, oh, that's not so bad. But the patient is hypertensive. That 97 is like you and I being like 60. So always pay attention to the history that she's supposed to be hypertensive. Now she's 97. So she's in real shock, in real trouble, and the lactate reflects that. So she is definitely in C on the matrix. So when you're down in C on the matrix, the arrows here represent your therapeutic intervention. So we already talked about blue, which is diuresis, right? What is the green? Right, inotrope support. So we have to bring her from, we did it, if all we did was diurese her, we would just make her from C to D. That's still not good. So we have to bring her from D to A, and inotrope support is how you do that. Now, those of you that have gone through heart failure rotation will know that even though we do the diuresis and the inotrope support, we do them simultaneously. And the process is called inotrope supported diuresis. You start them at the same time. And what that does is it moves you on the diagonal. So you skip D and you just move from C straight to A. And that's the treatment for this patient, is inotrope supported diuresis. And that's why we do that, right? We can do it this way, but it takes longer. And so if you start them simultaneously at good doses for both, you can move the patient along the diagonal. So the inotropes that we use, two, dobutamine or milrinone. And this chart here tells you what the differences are between them and why we choose one over the other. In terms of mechanism, the patient has known heart failure. So they were already on carvedilol. They took it, they've been taking their medications. So now you have this patient in florid heart failure, not doing well. And the question then becomes, she took her carvedilol. Carvedilol is a direct antagonist to the dobutamine. So you choose the milrinone because it has a different mechanism and will avoid any beta blockers that are there and just immediately begin to give you inotropic support. So that's something to think about. So when you get that history that they're already on all this medication, you want to think, which one am I going to use? The blood pressure is not bad, it's 97, so you can choose either one. If the blood pressure was a little worse, then dobutamine is superior because it won't bring the blood pressure down anymore. But you have to still take into consideration that carvedilol that's around. Fortunately, it's competitive inhibition. So you can defeat the carvedilol at the receptor by giving more dobutamine. So you don't start at pilling doses of 2.5 in somebody who's already on carvedilol. You start at 5 or 7.5 because you want to get to the receptor and knock off the carvedilol. So you can use the dobutamine, you just have to think it through. Okay, so that's the important thing. So you can either use the milrinone because it avoids the receptor altogether, or you can use higher doses of dobutamine to knock the carvedilol off the receptor. So either approach works. They're both moderate inotropic agents. So they will improve the inotropy and contractility a decent amount. They are both vasodilators. The interesting thing to think about, again, in your choice, milrinone is a vasodilator out of the gate. You put it in, starts vasodilating, makes it easier for the heart to contract. Dobutamine is a vasodilator at really low doses. So that 2.5, if the patient is not previously on carvedilol, you start at 2.5, you actually are getting some vasodilation. You're getting some reduction in afterload, and you're getting some inotropic support. So at a low dose, dobutamine will vasodilate. At higher doses, as you increase the amount of milrinone, you increase the vasodilation. Dobutamine is the opposite. If you increase the dose of dobutamine, you reduce the vasodilation. So that's something to again, think about as you're choosing which one you want to deploy. In terms of heart rate, milrinone, because it avoids the adrenoreceptors, it minimally increases heart rate. But again, that doesn't mean that the heart rate is not going to increase. It's vasodilating, so you can get a reflex tachycardia. That doesn't mean that when you use the milrinone, and sometimes you'll see that in the intensive care unit where they say, well, we're going to use milrinone because we're worried about the tachycardia. It's a vasodilator. It's going to add to your tachycardia because even though it doesn't stimulate the receptors directly, it's going to cause vasodilation, and you're going to have a reflex tachycardia anyway. So just think about the pathophysiology. Whereas the dobutamine is a directly chronotropic agent, so it will increase the heart rate directly. The onset, very important to pay attention to, as well as the offset. The onset is 10 to 20 minutes for milrinone. It's 2 minutes, 3 minutes tops for dobutamine. So if you need to get inotropic support quick, dobutamine is better because it just gets going. By the time you've hung it, it's going. So if time is of the essence, dobutamine should be the one you reach for. The next important thing is how long they last. You can see the duration of milrinone is in hours, 4 to 6 hours, and that's what a normal kidney. Dobutamine is also minutes, so it's minutes on, minutes off. So it's really good in that way. So you want to think about it, it's minutes on, minutes off. And when you need something that quick, it works. In milrinone, if you're sitting on a floor and you want to give the patient something and the nurses are going to take forever to transfer the patient to a place where that can continue, the Mirinone is your treatment because you give it, it's going to be around for hours doing its job. Dobutamine, you have to hang it where you are, right? If the patient is on the floor and the floor says, which we hear all the time, we can't do this on this floor. So we have to transfer them somewhere. You're looking at this patient, they're sweating. You're like, that's not going to be okay. Give them their bolus of Mirinone on the floor, and then you have hours to get them where you can do the continuous treatment. If you give them the dobutamine, you've got to hang it there while they're going. So again, that's where that on and off kind of helps you make clinical decisions. Let's see, is there anything else important here?
Do we need central lines a central line for the Mirinone?
No, we do all of those peripherally.
Sure.
Yeah, a good brachial line is always helpful because then you can kind of shut it off a little bit and draw some blood and turn it back on. Because we want to track the lactates and things. So yeah, so a good solid peripheral line is adequate. So the last case, 66-year-old male presented to the urgent care center, 3 or 4 days of progressive shortness of breath, orthopnea, and the night before he presented, he had 2 episodes of P&D. His chest X-ray showed bilateral pulmonary edema and small left pleural effusion. His NT-BMP was 6,800. He usually runs about 2,300, 2,500. His lactic acid, white count, procalcitonin, all were normal. His blood pressure on presentation was 210/91. And that was after he took some nitros because he was getting chest pain. So he was placed on IV nitroglycerin and then transferred to Advent ED. His ejection fraction is known to be 55 to 60%. He has moderate LVH from longstanding hypertension, moderate aortic regurgitation, and moderate mitral regurgitation. His comorbid conditions were paroxysmal AFib, which he was in when he came, and he is known as essential hypertension, of course, hyperlipidemia, COPD from 30 years of smoking, and type 2 diabetes. Okay, so where is this guy? He's in heart failure. E. Yeah. Okay, so he's an E, and when you can see our chart here ends with a map of 100, and he's above it. Okay, so again, he's on the outside of the matrix. So you've gotten the patient and you put him on the matrix. Then the question is, now you have him on the matrix, what are you going to do for him? So like the other patients, a 2-step process. What's the green arrow?
Vasodilators.
Yeah, vasodilators, exactly, right? Aggressive vasodilation, not too aggressive. We want to bring him down to 150 because he's poorly treated hypertension. All his end organs are used to hypertension. If you treat it too low, he's going to become the patient that was in C before. So you don't want to treat that low because you'll go past the line and you'll be down into the lower left box if you overtreat the hypertension. So that's the important thing. You just want to bring them down to where they're pretty much a map of about 100, 110 mean arterial pressure, leave it there, that's fine. So the green arrow is vasodilators. And then of course the blue arrow we've talked about is diuresis. So a 2-step process for that patient as well. Management of patients with heart failure with preserved ejection fraction. We don't know as much about it as we do the reduced ejection fraction, where we can immediately put them on GDMT and we're good to go. Once we treat this patient and fix them, get them out of heart failure with a diuresis and give them a little bit of vasodilator so that they're not in such a high afterload state. The question is what we do next. And the most robust data is start them on an SGLT2 inhibitor. If they're a woman, just start it. If they're a man, the heart ejection fraction, they tend to benefit when it's a little bit lower in the 50-55% range. A man above 65, we don't know if that works or not, but if it's a woman that's presenting to you, you get the SGLT. The ARNIs, again, the data is not as robust as the SGLT, but if you're going to treat hypertension anyway and he has good insurance, just put him on Entresto, right? So you then don't worry about the data, just give him the Entresto. If his insurance is so-so, then you can put him on losartan or valsartan. But yeah, if he can tolerate Entresto and he has good insurance, just give it to him. The orange there is the spironolactone. We're waiting for new data for the spironolactone because the data has been messy, and so we don't know whether it works or not. We know finerenone works, but it's very, very expensive, and most patients' insurance are not approving it. So we're stuck with either eplerenone or spironolactone. But the data is good enough that, again, if you need a blood pressure medicine, there's none better than spironolactone. So if you're treating blood pressure, just put the spironolactone on board because you're using it to treat blood pressure and not so worried about the data on HFpEF. And then ACE inhibitors and ARBs, like we talked about, they can be used as a replacement for the Entresto if you have socioeconomic and financial issues. And then again, diuretics are always needed. If you overtreat the patient with diuretics, again, you move them into a different box. So you always have to be careful when you diurese them nicely to stop. They don't always require maintenance diuretics. The HFrEF patients require maintenance diuretics, but the HFpEF usually do not. You look for iron deficiency in both HFrEF and HFpEF. Check the ferritin. The ferritin is less than 200. Give them some iron. So if it's above 200, check the saturation. And then again, manage all the comorbidities because they all contribute. The reason the data on HFpEF is muddy is because the etiology is so different from patient to patient that you can't get 300, 400 patients with the same etiology and test them. When you get 300 or 400 patients with HFpEF, they all have different problems. So the goal now is to treat all those problems, manage the blood pressure to around 130 or so, manage the cardiometabolic obesity. If they have it, start them on GLP. That has tremendous data supporting its benefit in HFpEF. Diabetes, the same thing. You can use GLP-1s, that helps HFpEF. AFib, control the heart rate. Sleep apnea, the appropriate treatment. Coronary artery disease, again, the patient comes in, the coronary artery disease caused angina, he went into heart failure, his angina is gone, and we might miss it. So many of these patients, we cath them and show that their ischemic status is stable. Then CKD, chronic anemia, and all those other things that you guys know how to treat very well. So the point in HFpEF management is to treat the comorbidities and then treat the blood pressure, but try to use guideline-directed medical therapies to treat the blood pressure. So that's it. So that's all I had. I just wanted to give you some ways to think through this. I don't like to belabor the point because most of this is going to be happening in your head. Okay, so we can have 20 more slides, not necessary. You get the point, and you want to think about this. And when you see these patients, they can be extremely sick. And the goal is for you to put them in a framework and then begin your treatment because you can select your treatment. And on the point of treatment, what do you think is going on with the patient in F? Right? Yeah, so they're in shock because they're almost off the chart. But they're off the chart on both the perfusion and the congestion.
They're trias.
Yeah. So that patient we're dealing with right now has septic shock, but they have underlying cardiomyopathy. So we're called because the patient's in heart failure, and they are. But when you look at it and you say, well, how do I get the patient to A? Right? How do I get the patient to A? So we talked about inotrope, but in this patient, you're exactly right, vasopressors, because we want it to go straight up. Just the same way we use vasodilators, they come straight down. Vasopressors go straight up. So that F patient, the first thing you do is start them on Nor-Epi. They go straight up and they get into that box. But you see, if you go straight up, you still are not where A is, right? So what do we do to bring the patient to A? Fluids. So we give fluids. So now instead of diuresis that moves us the other way, we give fluids to move in the other direction. So you put the patient on pressors, you get them into this box, you give them fluids, and you move them over to A. Not too much fluids, you'll move them to B. Okay, and we see that. So we see that all the time, right? You give them too much fluids, and now in B. So you don't want that. So pressors to get them in that upper box, a little bit of fluids to get them to A, and you're good to go. So the matrix game always helps you know where you are. It always helps you do the right thing or see when the wrong thing is being done. Okay, that's also important, is when you come to a patient and you're seeing all this stuff happening to them, and you're like, that's all wrong. None of that is helping the patient. Using the matrix helps you to sort that all out. And those are your therapeutics. And the matrix helps you choose which ones you want to use. Don't start with the therapeutics. Start with your framework, where the patient is in your framework, and the therapeutics will be easy. All right, that's it. Thank you. Thank you. Any questions? Yes.
The patient is like predominantly right-sided heart failure.
Mhm.
And it's like he doesn't have the same congestion for the lung, and he doesn't have the same perfusion. Do you use the same matrix?
You do, because the preload is what you'll see in right-sided failure. So it becomes a preload dominant thing, and you use the same matrix because the bottom line is congestion and preload. So you can see where they are. But that's a good question, because a lot of patients do come in with predominant right heart failure rather than predominant left. Okay, well, thank you for coming. So hopefully you learned something, think about it, put the patient in the right framework, and you'll be good to go.
Thank you so much, Dr. Agocha, for coming and giving us this teaching. Thank you. It's Claudia here.
We have one question from Dr. Ugoma.
Yeah, the patient that we saw was in class 4,
Mhm.
and on the game, he went from 4 to 3 and then from 3 to 1.
Okay,
We were just wondering about if we.
this one?
diaries him. Yeah, this one.
Uh-huh.
If we diaries, we're kind of worried about his blood pressure dropping even more.
Mhm.
It would make sense to go to 2 and then to 1.
It can, but if you start the inotrope, that will support your blood pressure and then allow you to do the diuresis. And that's why we start them at the same time. And that's why you move along the diagonal, so that you don't have to go across and then up. If you start it simultaneously, the inotrope will support your blood pressure, then you can be as aggressive as you need to be on your diuresis. But yeah, that's a good question. And if the blood pressure is really low, you can do norepinephrine as your support, because norepinephrine does have a little bit of inotrope and it does have a little bit of pressor. So if your blood pressure is, say, 90 or so, they're not really in clear classic shock, you can use the norepi to support you while you do your blood pressure. All right, thank you.